Hey guys, Floyd with Curbside to Bedside. On today's podcast, we're going to discuss spinal immobilization. Let's introduce our guest. We have ED physician and EMS medical director Walt Lubbers, your co-host Ryan Hunter, and we have...
My name is David Pfeiffer.
I know, I was thinking of...
We've known each other for years.
Okay. Paramedic and lecturer David Pfeiffer. I want to thank you all for coming on the show. I know this is a topic you guys are particularly passionate about. So let's just get into the meat of the topic. I think what really spurred this discussion is the joint position statement that the NAEMSP recently put out. And in this position statement, there was some collusion.
No collusion.
There was actually some compromise on a few things, and the verbiage in this position statement was not as strong as the verbiage in the previous position statement. I think that this position statement really made a lot of people think that they are against pre-hospital spinal clearance. What's your all's take on that?
I'll handle this one, if you guys don't mind, or at least take a crack at it. So you're talking about the recent NAEMSP, ACS, ACEP joint position statement on spinal immobilization or spinal care after trauma, for reference, published in PEC at the published dates, like August this year, so recently. And what it is a rehash. Kind of every 5 years or so, you get another statement from ACS and NAEMSP about like how we should take care of spinal stuff. It's not quite like that. The last one was published in 2014, came out in 2013 initially, and before that we got one in 2001. And the thing is that all these have all said the exact same thing, which is you can quote unquote clear or not fully immobilize a patient in the field after trauma if they are not drunk, not distracted, not confused, and if they have no signs of a spine injury, meaning no tenderness to palpation, no neck pain, and no neurological deficit. And basically, every one of these papers has said the exact same thing in different ways. The 2013/14 one was probably about the strongest worded and probably the most progressive. And then we get this statement that basically says the same thing, but takes a little bit more of a milquetoast verbiage to it. Basically, it's saying the same thing that we've said for now 17 years, but just maybe the language isn't quite as good, in some people's opinion. And I count myself among those people.
I don't think the language was as strong. I think there were a lot of people who were kind of just hoping that they'd come right out and say, we should not carry long spine boards on the ambulance, period. But that's not what they said. Instead, they created, quote, a menu of items that we can choose locally at our own EMS departments to manage a potential spinal cord injury. I think it was best hearing it from Dr. Brent Myers, the president himself, say that. He did a podcast, and we'll put a link to that podcast in our show notes. But that's kind of how he describes it. He says it was a compromise, and there are various ways that you can manage the spine or manage a potential spinal cord injury. Those ways may or may not be with a backboard.
I think a lot of the confusion or letdown about this paper comes from this misunderstanding on the part of a lot of providers that there's absolutely no role whatsoever for a backboard. And I don't think that's true. Even though I'm kind of anti-backboard, there are still some roles for it. I think what people have lost sight of is the nuances of like how the device is supposed to be used. So I don't think that there's a role for backboards as a therapeutic device when you have other tools. And they listed those other tools in the position paper, right? But you can still use a backboard as like a lifting and moving device or a patient transfer device, or you might still be having a backboard in like a mass casualty trailer where, that was the most durable and kind of like cheapest and most abundant resource to throw in there for moving a bunch of patients. So when you think about the backboard in that context, it's a true statement that what they put in their paper that you can achieve some degree of spinal motion restriction on a backboard. The question just becomes, is that the best tool to use? And the answer there is like very clearly no. If, a lot of people are looking for this, like you said, like the strong anti-backboard statement, but I don't think that was really the goal of the statement. It wasn't to prescribe what device to use. It was just to talk about, options.
Well, I'll say I think it was probably what those of us that were looking for a stronger statement were looking for is probably more like, yeah, backboards suck, absolutely, which backboards do suck. And you're right, I think they do have a space, but that space is probably to give the patient handles.
Right.
And at that point, like that space is probably then taken up, and you can use, as you probably mentioned, 100 other things that probably work just as well, or at least have as much evidence base rather than the slippery nylon board.
Right.
And I think one of the other things was not only we're looking for a strong statement that like nobody should have to ride on what we wanted it to say, or what I think probably people wanted it to say and why they're disappointed that it didn't, probably was that you were really looking for a statement that said nobody should go on a backboard, like nobody should ride in an ambulance on a backboard, which I think is an absolutely true statement. And then also that C-collars probably can start going the way of the backboard, which is that they don't really seem to be a helpful thing, and there's lots of stuff that can go wrong with them. And so in absence of seeing those, then everybody kind of says, oh, this is a bad statement, this is a failed statement. It's basically the same statement, but it didn't take it the next step that we wanted to see it go.
I think a lot of people are afraid for legality reasons. They think that if they don't fully immobilize somebody on a long spine board, that they're going to get sued. But that's not actually what this position paper is saying. You can use the backboard just for a transfer device and remove the patient from that device and secure them firmly on the stretcher. The position paper supports that. So you can keep doing what you're doing. You don't have to go back to full spinal immobilization for everyone. I'm really interested in the history, and I think Dr. Lobers had a few comments about the history, like exactly where did we get spinal immobilization from, and did it come from any sort of evidence? The WMS practice guidelines say that the concept of spinal immobilization has been predicated entirely on philosophical, theoretical, and medico-legal grounds, and the justification for its use remains unchanged despite more than 4 decades of widespread use. So do you guys care to comment a little bit on the history and how we got where we are today?
No.
Okay. I was looking at David because it's his society's practice guideline. But anyway,
I'll jump in later.
Okay, cool. Yeah, I mean, where do we come from? Back in the 60s, which is about the time that we sort of built this whole EMS thing in the United States to start off with, and kind of started to get away from hearses transporting injured or sick patients to the hospital, came this idea that we should probably watch out for spine injuries. And there were some studies that are, by today's standards, not really methodologically rigorous at all, and you can definitely debate the conclusions of, but they came to kind of scare people over the next couple of decades to say, like, well, folks said, well, we should initially just put people on a backboard and, use a C-collar, maybe head blocks or sandbags or whatever you got, if you're doing some sort of complex extrication maneuver, which means taking somebody from the bottom of the cliff up the side of the cliff. And that still makes sense. That's probably still a reasonable place where you could have a backboard or something like that. You just need a rigid thing to hold on to.
I think that that's actually the least justifiable use of a backboard.
What I think they were saying was that if you're going to do it, like, this is a reasonable thing to do. And it says the exact same thing, which I said, which is if you're going to pick somebody up and carry them off the side of the road, you don't want to drop them, so you give them handles. You don't want the thing to flex around a lot because we don't know if motion of the spine could actually hurt you if you have a spine injury. And there's a paper that I cite that's from the nursing journal in 2001. And the very first thing they said was that immobilization of the C-spine considered one of the most important factors of care. And it was acknowledged back in the time of Hippocrates that to minimize damage to the spine, stabilization of the neck should be achieved. So along with normalization of your humors, you also have to watch out if you have spine injury. So that's all been kind of ingrained in there. So we've sort of been fighting, or if you believe it, where all that comes from is, according to these guys, at least back in the nearly the prehistoric time, or at least the early historic times.
I think it's a part of a minimum, better, best list that the backboard is the minimum. It's probably slightly better than tossing them around on a bed of nails, but there are a lot more options that actually do meaningfully impact spinal care after trauma, like a vacuum mattress or something like that.
God, thank you.
Really that concerned, if you are so absolutely concerned about spinal care after trauma, you should invest in those options instead of just being like, well, we have a backboard, spinal care after trauma, yada, yada, yada. we kind of know that they're not really efficient. We know that they're there, but what Walt's saying is it really just serves to give the patient a set of handles. And that's about where its utility ends, and its therapeutic use also ends.
I might have a spinal injury because when you said vacuum mattress splints, I got a paresthesia. I think a lot of this goes back to this misunderstanding that when we started moving away from backboards, when that evidence became, I think, pretty clear, a few years ago, I think a lot of people misinterpreted that as saying, as meaning that spinal care wasn't important. And that's never what it was supposed to mean.
Patently false.
Yeah, spinal care is still super important, but it's just that the backboard, it turns out to be like the worst tool for doing that. And in a lot of cases, even worse than just directing the patient to move carefully under their own power with coaching and stuff like that. So spinal care is still really important. And again, that's where there's a lot of this confusion that comes into play. So people, I think, they were looking for this statement from NAEMSP's joint position statement, to say, make like a definitive statement. But the truth is, I think we actually don't have enough data to really tell us what is the best way to care for the spine. We just know that backboards aren't it. So there's a lot of these other devices that could be pretty good. And there's strong evidence for some other specific kinds of therapies. But I like that you mentioned the vacuum mattress splint because that is my preferred device of choice. And I think that the position statement should have been titled VAC mattress splints or GTFO, a joint position statement from anybody who knows anything about anything.
I feel like your audience needs a hero. It needs somebody to champion this cause and to make a bold statement here. So I will say, I think the problem realistically, and we sort of acting like we care about the backboard and the C collar and all that stuff. But in reality, none of it has an evidence base to it. It's definitely been shown to hurt people. And we've gone it wouldn't even be that bad if we hadn't gone so freaking crazy about it. Because part of that statement that I just read, that article that one of the nursing journals was citing, the point of that article was to say that they described this case of this patient who comes in after car wreck with a pole lodged through the back of his head, literally lodged through the back of his skull. And they're worried because they said the hospital did not follow best practices because they did not immobilize him in a C collar. The guy literally has a pole sticking out the back of his skull, and they're worried because they didn't put him in a C collar.
That's so genuine.
That is the absolute, and that's the greatest example of why this is actually a bad thing for people, because it takes attention away from all the stuff that makes a difference, like the pole and the hypoxia and the hypotension, all that other stuff, all the stuff that eventually killed this guy. And by the way, he had no injury to his cervical spine. It takes away from all that stuff and puts the emphasis on, we should give the C collar and the backboard as much emphasis in this patient's treatment as we do the rest of the stuff. And that's just patently untrue. That's absolutely nonsense.
So what is exactly causing people to latch on to the long spine board? Because I think that if it wasn't so deeply ingrained in our current practice and someone proposed it in today's time, that it would not be accepted because there's no evidence for its use. But there are maybe some medical legal, real or perceived medical legal implications in this. And I'm just wondering if you all think that is a rational thought process, that if we don't immobilize them, they could have this unstable spinal fracture, that if we move their head an inch the wrong way, that it's going to cause a debilitating spinal cord injury. Is that a real threat?
Well, so, all right, I'll shoot it back to Walt about whether or not that's a real threat as far as, how the human body works, because I'm just a simple paramedic. But I think that the answer to the question, the first part of that question about where did this come from, why we latched onto it, there's a few different layers to this onion. I'm tempted to say because, EMS generally has not had a very strong educational background. We've always been protocol driven and protocols written by other people, but that's not fair because there's actually a lot of physicians who push this too. And I think a lot of paramedics have had the experience, maybe more so in years past than recently, of taking a patient in who wasn't immobilized properly or something like that, like Walt was saying, getting yelled at by a physician, or taking a transfer from a sending physician who insisted that the patient be, re-immobilized or something like that. So I think this is something that's been really like pervasive throughout healthcare at all different levels. And I think it's probably worth mentioning that evidence-based medicine is actually a relatively new facet of medicine. Everybody from, surgeons down to whatever you perceive the lowest level of healthcare provider to be. And I prefer to think of healthcare as really like a flat hierarchy with people with different roles. But to a certain extent, there are, physicians kind of supervising the practices of others. From their level all the way down, everybody was doing this. And, this was championed by physicians and championed by people who were writing textbooks. And, the idea of really studying things scientifically and seeing what the outcome of patients were is actually, we take it for granted that that's actually kind of a relatively new perspective in a lot of areas of medicine. And there's a lot of examples of that, you look at high flow oxygen for patients, and, you look at all the crazy drugs that have been in the ACLS protocols over the years. And it goes on and on and on. So that's definitely one thing I think that's worth remembering about why we latched onto this. Then the other thing is just, dogma and mythology. And that's very common in medicine for a lot of different reasons. And then I think with those two things being said, it's actually kind of logical, right? If your spine is broken, we want to splint it. So let's splint it just like we would, with long bone injuries or anything else like that. It's easy now to be ragging on backboards with knowing what we know. But if you didn't have access to all this sort of evidence, you would probably conclude this was pretty logical. And it's kind of probably counterintuitive, the things that we've learned about spinal care. The rebuttal, though, to my own argument or my own perspective on this just now is I find when I talk to a lot of like old school paramedics who've been practicing for a while, actually some of those guys and ladies are the biggest critics of backboards because they talk about all of their experiences with patients sliding around on backboards while they're transporting, and just how crazy it seemed to be like log rolling somebody like over the hump of the backboard and all that kind of stuff. And to me, it seems like it's the people who became providers, became certified, started practicing like in the last 20 years or so. So after kind of the creation of modern EMS and the first curricula, and before we entered the age of evidence-based medicine, that kind of like weird period in between there, that clung to this the most. And I think what happened is just it became inculcated in them. The textbooks had included it. All the protocols seemed to reflect it. All your national registry testing procedures and all that kind of stuff focused on it. And so it just became ingrained,
Yeah, I think it's become mostly an accessory. I think we do it just because if we don't put the collar on the patient when we bring them into the hospital, we're going to get yelled at. But Dr. Lepers, I want to ask you the same question, but more directly. We're afraid that if we tweak the neck just an inch or two, they could have an unstable spinal fracture that could cause a debilitating spinal cord injury. And there's actually, I think, a paper or two that shows that patients have had disabling neurological injuries from unstable spinal cord injuries, and that some have attributed that to the mishandling of the patient by EMS.
Yeah, I mean, I will start off by saying I think this is a perceived threat. This is a boogeyman. It's not actually a real threat. If you look at the cases you kind of mentioned, and those are the same things that people have cited, and that's honestly how the backboard kind of got taken from this thing that we said, was good for complex extrication maneuvers, and now everybody's on it all the time. There were a couple of papers in the 60s and 70s up into the 80s that said, well, it's difficult to detect spine injuries, meaning if you got an X-ray, which was what was available at the time to diagnose an actual spine injury, not all those are going to show up. And some of those people that have had an injury are then going to get worse over the next couple of days. And that's absolutely true. Like there are folks who have non-fracture or not readily visible spine fractures who have sustained an injury to the spinal cord and then will get worse over a period of time. But there is absolutely no case that's actually credible that says this person was alive and walking around talking, had completely normal function, and then became paralyzed because EMS picked him up and didn't use a C-collar or backboard. There are a couple that sort of have been bastardized into that. There's a paper from, I can't remember the guy's name, Geisler, that's what his name was, one of the early ones to kind of bring this up and say, here's 39 patients that I took care of personally that had no problem, and then at the scene, and then when they got to me, they were tetraplegic or quadriplegic. And the problem is that there were 3 days between the scene and the time when this guy actually examined them, which we know people can get quite a bit worse. There are lots of cases reported where people just from positioning without even a spinal injury per se develop quadriplegia or paraplegia just because their spinal cord is getting stretched across a ligament or across a bony prominence or something like that. So there's lots of ways that you can get worse without having to, have been forced into some sort of position by EMS. And it is important to note, like, we're talking about pre-hospital spinal immobilization. We're not talking about clearance of the spine at the hospital or like evaluation of the cervical spine to make sure that there is absolutely nothing that could be going on with them in the setting of diagnosing everything. We're talking about, does the person need a backboard and a C-collar and maybe head blocks before they get to the hospital? And that answer, I think, is probably no. You can debate the best method to clear, quote unquote, clear somebody and not need x-rays or a CT scan. But in terms of who needs the C-collar and who needs the backboard, that's the idea that everybody has to ride in or anybody has to ride in with these things is probably not a real thing.
You said there's no direct evidence of EMS mishandling a patient and that causing the spinal cord.
Sorry, not that EMS didn't mishandle anybody, because there are lots of cases where the person gets dropped, like on their head, or they fall out of the bed, or this one.
I do that all the time.
Yeah. Seen David do it 2 or 3 times.
At least.
And, but there's this one case, for instance, that 2001, this guy puts out a case series. And he said 5 incidents of worsening neuroexam occurred during C-spine immobilization. 3 of those were because they forced somebody with ankylosing spondylitis into a neutral position and paralyzed the guy when that happens. One was when there was an 83-year-old guy who was refusing to lie down and stay recumbent with a C-collar on, who then developed a worsening neuroexam. He already had some paralysis, but he developed a worsening exam, which they say, with his quickly ascended with his self-manipulation of the neck, which you can't really say. Like, he already had a C-collar on, so shouldn't that be the protective thing? He's already done it, but then he got worse regardless of it. The 5th one was a person who was actually getting a halo that got forced into an awkward position and then had a worsening neuroexam. So all the stuff that's out there, everything that everybody says about how people are going to get worse, this guy sneezed and then he was paralyzed, like, that doesn't happen. It's over a gradual period of time, and it's even sometimes folks that did get the quote-unquote right treatment.
When it comes to terminology, we have a lot of different terms for this. There is traditional spinal immobilization using a spine board, head block, cervical collar. And then there's this other term that I think is relatively new called spinal motion restriction, where you use a cervical collar and you secure the patient firmly to the stretcher. Can you actually immobilize the spine?
I don't think you can, outside of surgical fixation. Because
and even
our body as a unit, being under the influence of physics at every moment in time, is going to have some degree of flexibility and movement in it.
Counterpoint, our body is a wonderland.
Our body or your body?
Your body.
Noted. That's what you guys do in the woods. Wilderness Medical Society.
We do a lot of things in the woods. I agree with you, though. I think that term immobilization has always been a total misnomer. And that's part of the reason that a lot of the stuff has been misunderstood, is because we framed it incorrectly to begin with. And so if you say that the goal is spinal immobilization, then you start coming up with a whole bunch of, ridiculous tools and contraptions and methodologies to try to do that. And you're never going to be able to, and you probably end up causing more harm and all that kind of stuff. So I think that this more contemporary terminology of spinal motion restriction is just obviously more accurate, but also connotes a more realistic understanding. And so once you say spinal motion restriction, it kind of opens up space to start looking at some alternatives, right? Because anybody who's ever worn a C-collar, practiced with a C-collar as a student, put a C-collar on a patient, knows that the patient can still move their head and neck around.
Yeah. I mean, if you look at what you've got right now, which is the practical way that you're going to do spinal immobilization, if you were going to immobilize somebody, is on a backboard, right? Or maybe you got a scoop, or, if you're really baller, then you've got the vacuum mattress. And I'm with David. I think that's absolutely probably the best way to do it right now.
So good.
But the use, exactly as you said, when you say rigid something, that probably means that what you're doing is you're fixing the spine, which is this long, curvy, semi-flexible, kind of like a slinky. Essentially, if you've got a long, curvy slinky and you fix it at a couple of points to that rigid thing, either the backboard or the C-collar or whatever it is you've got, if you fix it, it'll hold still at those points, but it will still flop around in the middle of those. And if you cut the slinky in between the 2 points where you've got it fixed, those two ends will still jiggle around. And that's exactly what you see. One of the points of this is or what we see is that when you put somebody on a backboard and a C-collar, you reduce visible motion of the body. Yeah, they can't move as much, but we've really never looked at, or at least not looked at very much or very well, how well you actually keep the spine from moving. And the answer is it doesn't keep it from moving very well at all.
Interesting points. And I think that the only possible way it could be useful is in an unconscious patient, or even in a conscious patient. It would just serve as a cue not to move their neck. But I think we all have had experience with that one patient where you inappropriately apply a C-collar. Actually, I think if you properly apply a C-collar, then it's going to distract the neck a little bit. It's going to be really tight, and it's going to cause some discomfort. And that discomfort will cause the patient to move their head even more.
Well, not only that, like it actually, if it's unstable, if the injury we care about is the unstable one, the one that doesn't have the support of the rest of the spine with it, or at least doesn't have some of that support. If you put all that in there and you put a properly fitting C-collar on somebody, it actually not only pull the head apart, but probably twist the spine a little bit. So there's a couple of really good papers from Ben Galim's group who did just that. They basically did CT scans after they put a surgical model in a cadaver. They completely disrupted one of the levels, and then put them in a C-collar, did the CT scan, and looked at where the pieces were at. And the piece actually gets shifted and turned quite a bit if they have an unstable spine. The C-collar actually makes it worse, as well as lift your whole head up by about, in one of the cadavers they looked at, by about 1.5 centimeters. So all of a sudden, just from having the properly fitting C-collar on, it literally pulls your neck apart 1.5 centimeters.
And you still have 30 degrees range of motion.
Yep.
In healthy volunteers.
Are you saying that cervical traction is bad?
Well, the cervical traction has a different meaning. We shouldn't be applying cervical traction on somebody. There's means for a therapeutic use of it, but that's with a neurosurgeon. And a lot of people will have a worsening exam, and you can really F people up by doing actual traction on the neck itself. But that's what a C-collar does.
Is that still a practice?
It is. Not widely, and it sort of depends on what the injury is, but for a specific number of a very specific small number of cases, then like traction is actually the thing that will pop your facet back over.
Oh, no. I mean, there was a time in EMS training, I think like when I became certified as an EMT around 2001, that the specific guidance was to pull inline traction. And hold C-spine control, or, gentle inline traction, I think was a specific phrase. And Floyd's question and your commentary kind of made me wonder, is this something that we're still seeing out there from EMS providers?
I think what I'm really seeing is everybody gets a no-neck C-collar, and they just put it on because they have to.
I think really what we're laying the groundwork here for is emergency response chiropractors to do some roadside adjustments. But the most people don't move their neck when it hurts. Like most people don't move things that hurt them. So if your neck really hurts because you have a distracted spinal cord injury, you're probably going to try to not move the thing that hurts. We see it all the time with regular fractures and stuff like that. So this notion that we need to force someone into this hard collar that has been, at least to some degree, proven to further distract and aggravate the injury and feel like we're doing good and basically doing the law enforcement equivalent of stop resisting, I'm going to help you. Like, my neck hurts. That thing you just put me in hurts my neck a lot more. Can you please stop? And then our response is, well, no, I'll get in trouble. Or no, you'll sue me, which is also not patient-centered care.
But Ryan, McKee in the Journal of Trauma in 1990, for instance, reported on the case of an 82-year-old guy who had a type 3 dens fracture, which would theoretically might be unstable, maybe, who had no symptoms and no pain from it. So how can you say they couldn't possibly be? How this person obviously had an injury and they could have gotten a lot worse.
But I think we're chasing shadows with a lot of it, because I mean, in any sort of universe, you could always say there's always the potential for anything to happen ever.
Yeah.
But I just don't think the statistical incidence of these types of injuries that actually incur patient harm is there to warrant the amount of attention they receive.
Also, rigid C-collars and backboards don't work. That's the thing. It's not just about the harm that they cause. It's that they don't achieve the goal of actually immobilizing the spine.
They achieve the goal of making us feel better about ourselves.
You know, we can be using other devices that provide the real benefit that we're going for, which is basically a reminder to the patient not to move their head, or just to keep the head from flopping around, you know, for a patient who's unresponsive and unable to really control their own movement. So if a patient is awake and able to follow commands and able to basically perceive pain, then they're probably going to be self-splinting. And if they're not, then we can be looking into things like soft collars, blanket rolls, the wings of a vacuum mattress splint, which is one of the reasons that I really like it. Some other things like that. It may even be reasonable, in my opinion, to just like tape somebody's head, just a piece of tape across the forehead onto the stretcher rails, just to keep that head from rolling around back and forth with bumps and things like that.
Well, interestingly, that's the thing that actually has been shown to do the least amount of motion is sandbags and tape the head to the stretcher.
Yeah, so
like that seems to keep things pretty well.
So caring for the spine and minimizing movement is still important, just as it is for a broken long bone or not disrupting clots that are forming in, organs and stuff like that. I mean, it's still important to handle your patient with care, but these devices that we've been fixated on, no pun intended, just aren't getting that job done. And so then it's like nothing but harm. You know, when you're looking at these, you try to take a utilitarian view of things in medicine and say, well, there could be some side effects. There may be pain, there may be discomfort, but they're achieving greater good. There's no greater good with these rigid devices.
So I want to play the devil's advocate for just a second, because this is the argument that I hear. Like everything, there's a number needed to treat. For a select few number of patients, you do help. There are some patients that might get benefit from a cervical collar. There are these unstable fractures that are completely asymptomatic, and any assessment that you do,
excuse me, Floyd,
any assessment that you do will not pick those up. So let's say we know there are patients that are harmed by cervical collars, right? Those are patients with traumatic brain injuries, respiratory problems. And let's say that we don't try to force somebody having neck pain into a neutral position just to put the collar on. What harm does it actually do to the patient for them to be on a long spine board for 10 or 15 minutes?
So I'm going to salt that line of reasoning because I hear it a lot applied across a great myriad of all sorts of pathologies and treatments. It's circular reasoning because it completely negates the fact that we live somewhat in a universe that is governed by math. And I'll get back to that in just a second. There's always going to be the one, that one in a million, the whataboutism. There's always going to be one thing that slips by. There's always going to be the CT scan that did not pick up that fracture, because none of our treatments, none of our diagnostics are absolutely infallible. So basically you're arguing against something that is in a way unwinnable, because you have to acknowledge the fact that, well, that one person, well, why should we treat 100 people the same way? That's probably going to cause harm for that 1 in 200 millionth person.
But I'm saying if we select the people that we know that it's going to cause harm to, then we can decrease risk to those, decrease the number of harm or number of patients we're causing harm to prevent a devastating neurological injury to one patient.
If this is actually covered in the 2013 NAEMSP paper, like if you thought that spinal immobilization as we do it, for lack of a better term, spinal immobilization, if you thought that was going to be a thing that actually could prevent an injury from getting worse, if that was a real thing, then the number needed to treat would be somewhere in the hundreds of thousands of people. And certainly the number needed to harm is less than that, depending on which exactly harm you're looking at.
That one patient, you might see that one patient that I hear talked about as a devil's advocate for the use of spine boards and stuff like that. You might see them in a career, but you probably won't.
But you also, like when you talk about the asymptomatic patient, none of these people are actually asymptomatic. The ones that have been reported before, for instance, there's one here that says 82-year-old guy with type 3 dens fracture, no pain, which is the one that I ribbed Ryan about before. It's also worth noting that lots of old people fall and don't actually have, they fall and then they have a little bit of neck pain and they get a type 3 dens fracture, which is not really all that unstable. And then it forms this fibrous thing that doesn't show up on x-rays and then it heals up. So we're basing our entire thing based on this idea that one 82-year-old guy who could have had this fall and this fracture 30 years ago that just never had reossification of it, we're saying that's this asymptomatic person. There's this other one they cite from 1982. They say there's this young woman who was drunk. She fell out of a car. How you fall out of a car, God, who knows? But she walked into the emergency department 6 hours later, not paralyzed or anything like that, with wrist pain, which she was actually there for. And she was eventually found to have some neck pain and some tenderness. So it's not that she's asymptomatic. They minimize how symptomatic or not she is. She's essentially, quote unquote, asymptomatic, but she's not actually asymptomatic. And she's found to have an unstable neuroexam. And she actually gets like the tongs and the traction and her head pulled off of her spine and gets eventually fixed. And they say, oh, thank God that we found it. But what this actually shows is that you can walk around with an unstable injury and you don't die. So if we're like being careful, taking care of these people and not only not letting them walk around, but not like tossing them against the wall, then they're probably going to be just fine.
Which is what we should have always been doing in the first place. Right?
Tossing them against the wall?
I like that.
Taking care,
Stone Cold Steve Austin, all of our spine patients.
Sorry, I interrupted you.
So we should have always been handling these patients carefully and never throwing them around and jostling them around. And if anybody thought that just because you're on a backboard and a rigid collar, we could be handling you roughly, it was never accurate. And if you weren't going to put a collar on and put somebody on a backboard, that there was no need to handle them with care is not accurate either. I think it kind of goes back to what we were talking about earlier, which is that these devices didn't do what they claimed to do or what we thought they were going to do. So Floyd, your question about, what about this unstable injury? Well, okay. So put a rigid collar on that patient, get in your time machine and go back to, 1994 and put this patient in a rigid C collar. It's still not stabilizing that injury. Their head can still move around. Their head still has to be manipulated to put the collar onto them. They can still rotate their head, and we've all seen that and experienced that. And if you haven't as a provider, you haven't been paying attention. And so if that goal was never being achieved to begin with, then why not, if you're going to put something around their neck, right? If the presupposition is that we have to provide some support to them, make it a soft collar, a blanket roll, something along those lines that provides whatever mechanical support you think they need without causing sensations of trouble breathing and nausea and claustrophobia and interfering with airway management and distracting the cervical spine and decreasing drainage from the cranial vault and all of these things that we know that rigid C collars do.
I don't think the position paper approved soft collars.
They didn't, which is why it's lame.
And everything, the fear, the boogeyman out there is that, Ryan, you fall, you go out and we go drinking and, like some sort of drunken moron, you fall and you hit your head on the curb. And then you get this unstable spine injury. And the fear that everybody's got is that, I lay you back on a vacuum, or I lay you back on just the ambulance, cot. And then you tilt your head one way just a little bit and there's this little pop sound and then you're paralyzed from the waist down. Or for that matter, from the shoulders down. And that's not really the way it happens. Like it's the little motion, anybody that's whacked their funny bone, knows what happens when you tickle a nerve. It hurts. It gives you this sensation, but you're not paralyzed after that. Like that doesn't happen. It takes time. The whole thing, if you don't physically tear apart the nerves themselves, if you don't jam a little piece of sharp bone into the spine itself, into the spinal cord itself, then you don't actually like rip these nerves apart. Now you can, because of the way that the spine is, or that the spinal cord sits in the canal, if you pinch it, if you stretch it over something and a piece of it gets tickled for a while or gets pushed on, that part will get ischemic and then that part dies. And if you take out one little section of it, then everything below it, can't get signal anymore. That actually happens. There are folks that get a vessel occluded, get like a vertebral artery occluded, or one of the arteries that feeds the cord itself. And when you pinch that off, because you've got this spine fracture where the cord moves inside it, that happens. That gets you paralyzed, but it doesn't happen right away. It takes time.
So would it be reasonable to suppose that we should quit looking at this from the perspective of that 1 in possibly a billion instantaneous spinal injury and more of a holistic, this is an injury process, and adjust our care accordingly?
Yeah, we're worried about all these little tiny we're worried about the little tiny movements that everybody loses their mind about. Does he move 10 or 20 degrees one way or the other? And that part probably doesn't make any difference at all. It's all the other stuff. It's everything on balance that really makes a big difference. So,
and again, if you were concerned about that movement, so let's assume that this was all valid to begin with. It's like, oh my God, if we move the spine just a little bit, these person's going to be paralyzed. Well, then putting somebody in a C-collar and putting them on a backboard is the worst thing you could do. And, think about what it takes.
Why is that, David?
Well, think about what it takes to log roll somebody onto a backboard. Think about what it takes to manipulate somebody's neck to get it straight and in the right position to put the C-collar on. It doesn't make any sense. So either way you slice it, the tools that we've been using and that some people are still clinging to just don't make any sense. And I think if anything, that was kind of the letdown of the joint position statement, which is they talked about a lot of really good tools that could be used to do this effectively, like scoop stretchers. And that's my preferred method, by the way, of putting somebody on a vacuum mattress splint. I'm not a big fan of log rolling. Recovery position is actually pretty cool for airway management. And you can put somebody in recovery position in a way that's fairly spine friendly and spine neutral. But what's ideal is if you could just pick somebody up with a scoop stretcher, lay them ever so carefully into a vacuum mattress splint, essentially in whatever position you found them in. And then kind of, almost like you're kind of like shrink wrapping them into that little vacuum mattress splint. And so you are splinting them and providing that spinal motion restriction in basically their position of comfort. That's really ideal. And you don't need collars and you don't need tape. You just have this nice, tidy little package. But if you're not doing that, and you think about like log rolling somebody and log rolling them up the hump of that, side of the backboard and stuff like that, you're definitely 100% moving the spine around in a big way. And we know that because we've studied it. And I'm sure Walt could point us to those specific citations and authors, but there's been a lot of cool studies. And one of my favorite ones too is the one, and I would have to look this up and maybe refer people to the show notes where we could list this specifically, but a study where they put little paper targets down the side of a patient, like pasted little targets to them. And then they put lasers on the walls of the patient care space. And they did procedures like log rolling and putting on backboards and then putting the backboard in an ambulance with these little lasers fixed to the wall. So that was their method of studying movement. And what they found was just really, really significant movement from, where those lasers were calibrated directly on the targets. They measured, how far those targets moved. And there was just like a really profound amount of movement with all of these standard techniques that we had been using. So I just think this whole assumption has always been kind of like garbage to begin with.
I really want to talk about managing the airway in a patient with potential spinal trauma, because is it okay to loosen the cervical collar when you're trying to intubate a patient? Does inserting the laryngoscope blade and lifting up actually cause enough motion to cause a spinal cord injury? And two, the manual inline stabilization, even if you loosen the collar, that still significantly increases the rate of difficulty during intubation. If we wanted to put the person in a true sniffing position or ear to sternal notch to increase our chance of successfully intubating that patient, do you think that the benefit of properly positioning them for airway management outweighs the risk of causing a spinal cord injury?
And of course, we're not talking about, or hopefully we're not talking about like taking the guy and folding him in half and then straightening him back out. Yeah. So what you should do if you're going to intubate somebody in a C-collar is go ahead and loosen the C-collar and loosen it a little bit more, and then kind of grab the right side of it and pull it off of the patient and like kind of toss it out the window of the ambulance because that's how much good it's going to do you.
I get it now.
Yeah. But honestly, manual inline stabilization is probably just as bad. And when we say manual inline stabilization, I'm defining that as somebody grabs the dude's head and kind of pins it to the mattress, like we've kind of seen everybody do. So that's been studied as well. There is actually evidence about this. For instance, the Canadians looked at it from the setting of an anesthesiology standpoint. They took a bunch of people, and then they had anesthesiologists who claim themselves to be expert intubators, and I have no reason to think that they're not. They actually did manual inline stabilization versus no manual inline stabilization. They randomized these people and they did it before and after. And they actually had to stop the trial early because they found that 50% of the time they were unable, anesthesiologists, guys that are supposed to be best at this, they were unable to intubate the patient with manual inline stabilization. In a couple of cases, they actually goosed the patient, which anesthesiologists would consider to be like, this should never have actually happened. But 95% of the time, without manual inline stabilization, able to get it on the first shot. They also said it significantly made the Cormack-Lehane scale worse for these folks. And, part of it comes out that even within this same thing, you can kind of tell who was writing it and what their stance on manual inline stabilization is. Obviously, it's a negative trial. They even bring up in the discussion, like, probably there's a big issue here because you're going to pin the head down to the table. And when you use a laryngoscope to grab the tongue and the jaw or whatever it is, what actually happens is you're going to apply force to the cervical spine itself. So you're going to internally try to move the spine. And if you just lift up while you're pinning the head down, if you try to lift up on the spine, all that force gets transferred directly to the spine itself, the one floppy thing. So if you've got an unstable injury, that probably makes things a whole lot worse. If you were going to try to avoid moving the spine, if you think that's the thing that could hurt, that probably hurts a hell of a lot.
I think it's also worth pointing out, as always, that the goal of airway management is not intubation or really any one device usage. It's oxygenation. There's a lot of ways to do that. So, if you decide that intubation is truly what's necessary for your patient, there is bimanual intubation and ELM, kind of synonymous kinds of techniques if you need to keep somebody's neck from moving around or head moving around too much. But then there's also your rescue airways, blind insertion airways, supraclavic airways. Now, they go by a variety of names, but let's not forget about the King LTs and the iGels and devices like that out there. And then also, a lot of patients can actually be oxygenated perfectly fine with just simple adjuncts.
Yeah, or just intubate them. Like, what are the biggest thing? What's the biggest cause of secondary injury to the spine? It's if they get hypotensive or hypoxic. So if you're going to manage the airway, just manage the airway, and don't worry about the rest of it. Again, your little tiny motions with the laryngoscope, even if they do have an unstable injury and it's right underneath the laryngoscope, that's only going to last for a second. And in exchange for getting good oxygenation, good ventilation, and not causing the person to Brady down and become hypotensive at that point, that's almost certainly worth it. But again, the problem is even these guys mentioned in their paper, they say there's no evidence that manual inline stabilization helps anything. There's not a study that shows that it actually improves outcomes, and there won't be that study, by the way. But they say it would be, there's ethical considerations if you even were to study it. And once again, that's the whole culture around this spinal immobilization stuff we've just gone crazy over. So we've got this thing that makes it more difficult, super increases the chance that you're going to fail at this thing, which if anesthesiologists can't do it in a fasted patient in a perfect setting, how are you guys going to do it out in the back of an ambulance where our success rate is, 50, 60% to start off with? Of course, people are going to get hurt doing this. So let's make it as best as we can. Let's try to avoid the other things that we know absolutely no hurt people and sacrifice a little bit of the this might do something maybe, but they're going to get hurt a lot worse if we fail at this.
The TCCC states that selective spinal immobilization is contraindicated in the penetrating trauma. And why is that?
My understanding, which may be corrected here shortly by an actual physician, because I'm just a simple paramedic.
That's all right. You're people too. Go ahead. Give
I've
it a
said
shot.
that a couple of times because
Give it a swing.
It's a pet peeve of mine, that trope that just because you're a paramedic, you have to defer to some other kind of healthcare provider for your knowledge and guidance and so forth. So I hope listeners understand that I am being facetious about that. But I think what
now we have a whole other set of issues.
Oh yeah,
I think Walt was getting angry that the help was talking back.
Yeah, I can tell. The evidence that's undergirds that T3C suggestion, which is also seen in PHTLS.
T3C.
Yeah, isn't that what you
Tactical.
Isn't that
care?
Isn't that what the military people call it?
No.
All right, Floyd, edit this out. All right, so I think the research that underpins that TCCC guidance that you also see in PHTLS and other sources, other curricula, is primarily two things. The first is that in a penetrating injury, any injury to the spine has probably already occurred, right? If a bullet is lodged in your spine or a knife severs your spinal column or something along those lines, that injury has already occurred. You're not going to undo that with any treatments in the field. You're probably not going to make that situation any worse, along the lines of what we've been talking about this entire time. The second thing is that spinal immobilization is probably going to delay care, or not care, delay transport to definitive care. So
it will.
Rather than taking the time to do the whole backboarding procedure and even to just lift somebody up and, safely with a scoop stretcher and put them on a cot, that kind of thing, it's just distracting from other more important interventions.
And I think part of this too is, why do we specifically call out penetrating trauma as being contraindicated with spinal immobilization and not blunt trauma? Because penetrating trauma actually has studies behind it that show if you put a C-collar on somebody with penetrating trauma to either their neck or their head or their body someplace, that they're more likely to die. And so when people actually see evidence behind it, they go, oh my God, we can't do that. But realistically, there's no reason that, when you really practically get down to it, if I stab you again after your drunken foray, you get out of the hospital and I decide to go finish the job. So I stab you in the throat and I go back and I give you an unstable injury in your neck. That injury remains nonetheless unstable, whether you were in a car wreck that caused it or whether it's because of my apparently ineffective slashing action at actually finishing you, because you for some reason didn't quite die yet. So while penetrating injuries are absolutely terrible, and they're bad and people die from them all the time, they're super, super important. We actually have stuff to say that the C-collar seems to make things worse, which if you had the same study for blunt trauma patients, then you'd be able to say the exact same thing. But that study is just not out there.
But we can extrapolate from that, because I think if we start to infer based on expertise and based on kind of the massive evidence that we have, then it adds up. So, you can just kind of start kind of imagining a little bit. So if you have really bad penetrating injury and you are starting to form some clots, internally. So now we strap you down to a backboard and we kind of pull you into a little bit of an unnatural position and we pull some of those apart. That's not good, right? If you are in the trauma triad of death and you are maybe a little bit hypothermic, and now we put you on a cold plastic backboard that increases your conductive heat loss, then outcomes are going to be worse. And again, we can use the things that we know about medicine to start to take an educated guess about why it is that backboards and the way that we've typically been handling spinal motion restriction are leading to these negative outcomes after penetrating trauma. And I completely agree with you. We can extrapolate that onto blunt trauma, and it paints, I think, a compelling picture that we should just stop using these tools.
Is mechanism of injury and or the patient risk factors ever a reason to immobilize someone, even if the exam is normal?
So I think that the MOI is irrelevant to whether or not you need to put them in spinal motion restriction. But I think that MOI is relevant to, I guess what I would say was this larger issue of spinal care. I think we need to remember that The trigger for doing a selective spinal clearance exam is whether or not they have an MOI that even suggests a spinal injury to begin with. So I don't think that the mechanism really makes a difference about whether or not backboards are good or bad or rigid C-collars are good or bad, but it does help you determine how much effort or not effort, but how much focus you need to place on specific considerations of the spine. Right. So in other words, somebody who's tripped over the curb and is, clutching their ankle when you arrive on scene, it's always irrelevant. But, if they fell from a great height, if they had a rollover, if they got thrown through the windshield of a vehicle, all that kind of stuff, then I mean, you need to think about spinal care in general. It goes back to this premise that we don't just throw the baby out with the bathwater. We don't just ignore spinal care. But whether or not we really need to go down the whole consideration pathway of, literally unrolling the vacuum mattress splint and doing that whole thing, that's where that mechanism becomes relevant. Just like you're going to do kind of a differential diagnosis process for almost any condition in any patient.
If the exam is completely normal, but the mechanism is severe, is there ever a reason to immobilize that person even with a normal exam?
Oh, I say still no. And that
also vote no.
Comes back. I said all those words kind of unnecessarily because...
Like a true academic.
Let me restart. Let me reframe my thoughts. No, because when you look at the spinal clearance criteria from the Nexus studies, it starts with mechanism, right? So you have a mechanism in the first place that makes you wonder, does this patient need spinal care? And then if you go through all of those criteria and they're all negative, then you don't need to immobilize them. So if the mechanism could have been, I fell from an airplane and my parachute never opened. But if the patient isn't intoxicated, doesn't have a distracting injury, is able to move their head and neck, 45 degrees without pain, doesn't have any paresthesias, if all those things are negative, then they presumably don't need spinal care.
The mechanism provokes the question. It does not decide the answer.
It's only relevant if you think that your treatment actually makes any difference for the patient. So,
sick burn.
If it doesn't do anything, then it's never relevant. Mm-hmm.
So let's do a quick rapid fire round and tell me what harm spinal immobilization causes. What specific harm does it cause?
I don't understand that last question, but one of the harms that causes is reduced tidal volume. Ryan.
Pressure ulcers.
Pain, cancer, causes cancer. Cancer is the final answer.
Rigid C-collars, increase intracranial pressure. Back to Ryan.
You took mine. God damn it.
Okay. Ulcers. What about if we just put them on for a 5 or 10 minute trip?
So considering that you can get a grade 1 ulcer in about 30 minutes, which is an actual grade 1, not I've got a little hot spot on my back. That is a legitimate pressure ulcer in 30 minutes.
So you can still get it in a short amount of time. You can still get pretty significant pressure ulcers, especially if they're elderly, et cetera, et cetera.
If you think
that 30-minute parameter is in young patients. That's not considering the patient that has like peripheral vascular disease, or they're elderly, or they have some other condition that affects their dermis.
And your 15-minute trip is going to be added on to my 30 to 40 minutes of dicking around in the hospital, not getting you off the backboard.
And if we put them on a board or put a collar on them, does that increase the likelihood that they're going to get imaging? And can it be harmful?
Absolutely. If you put a board, underneath somebody, and you put a collar on somebody, and you pin them down, 100% of people are going to get pain that they didn't have before within 30 minutes, which everybody's going to be on the board for 30 minutes thereabouts, if they're that lucky to get off in that point. And then I, as being the facile emergency physician, I'm going to go in and say, oh, look, Ryan, after his minor fall, it's damnedest thing. He has pain all up and down his spine, though. And I don't know if that's because he was laying on the board and he's got the C-collar on, or because he's got unstable injuries throughout his entire spine. But damn it, I'm not going to be the one that's going to miss this stuff. So I'm going to scan his entire spine. And while I'm there, I'm going to go ahead and irradiate his chest and his belly. And I'm going to get the gonads. And in order to keep him from bleeding, I'm going to try to irradiate him a couple of times. Go do a bony pelvis as well. But I don't know that any of that didn't occur because he had the injury. All I know is that he hurts now. And as long as you keep the C-collar on him, he's going to continue to hurt. So there's no way for me to prove it otherwise. So yes, I'm going to scan
why
him.
Those Nexus criteria were formulated to avoid that.
Speaking of Nexus criteria, so we extrapolated a lot of our spinal clearance stuff that we have in our protocols from the Nexus and Canadian C-spine criteria. And I think there is a group of people out there who would say that you cannot formally clear a patient without imaging And there are even some who will say that pre-hospital providers cannot effectively clear someone. A, can you clear somebody without imaging? And B, can pre-hospital providers effectively use that criteria?
You can effectively apply the nexus criteria. That's been shown. That's been shown between 2001 and 2009, if I recall, in a bunch of studies. It said, yeah, not only can pre-hospital providers use this thing, but when you do it, you don't miss clinically significant injuries. They're out of like 18,000 patients or something like that. No clinically significant spine injuries were missed when pre-hospital providers applied what is essentially the nexus criteria. Now, are you clearing them from like saying, no, they don't need imaging? No, but again, we're not talking about clearing them. We're talking about, do they need a C-collar and a backboard right now? And what we can say is that if pre-hospital providers use this stuff, they can identify all those injuries that might make a difference if you thought that any of that stuff actually makes a difference.
Yeah, I think, correct me if I'm wrong, but I think clearance is kind of a misnomer. We are deciding whether or not to apply a treatment and trying to capture whether or not they might have a clinically significant injury. I don't think you're necessarily blessing off on the fact that they don't have a spinal injury. We're just saying, yeah, you meet the criteria to be spinal motion restricted, or no, you don't. Or even if you don't want to do the SMR, is there a possibility that you could have something clinically a clinically significant injury of your spine?
Which is basically the same thing we do for every patient.
For literally everything?
Yeah.
So I don't understand why it has to have its own dedicated thing.
I don't know why people get so wrapped up in this, though, to begin with, because it's like, any patient.
You're considering a differential and you're considering a treatment option for that differential.
Assess them. You figure out what is the thing that seems to be wrong with them according to the best information you have, which ideally is evidence-based, and then you proceed. And I know I'm being a little bit, maybe high-minded, maybe even naive here, but if you're
just a paramedic.
Just a paramedic. If you are, practicing ethical medicine and involved in, informed consent and declination of treatment and so forth with your patient, you are hopefully saying things to them like, I've performed this series of tests, which gives me a high degree of confidence that you don't have a spinal injury, but I can't be sure. And so here are things to watch out for. Here are changes in your condition to be aware of. If you're concerned at all about this, then you should seek further care. We're happy to transport you right now if you're not sure, if you're not comfortable, all that kind of stuff. So, hopefully paramedics aren't out there, or anybody else for that matter, EMTs and wilderness first responders. Lots of people get trained in spinal clearance. Hopefully nobody's out there just being like, yep, you're good, sign here. Right? Because that's always irresponsible.
I have one final question, then I'll let you guys kind of say whatever's on your heart. What is considered a distracting injury? Would a femur fracture be considered a distracting injury just by virtue of it being a femur fracture?
I can't recall the study author right now, but the literature has proven that patients with femur fractures can still accurately describe their spinal pain. We have studied that. We have found that femur fractures are, in fact, not a distracting injury specifically. But to the larger question, I think that a distracting injury, at least in theory, is any injury that would distract a patient from localizing, spinal pain or paraspinal pain, but also may even distract the provider. So there's a lot of things that could qualify as distracting injuries, and to a certain degree, it's probably subjective. But the interesting thing is that we actually did study femur fractures specifically, and patients had high inter-rater performance on being able to localize pain elsewhere in their body.
Yeah, that's the classic distracting injury is the femur fracture, but different authors have, admittedly, they just say, well, I picked any long bone fracture. Well, what about like ankle? There's a long bone and kind of involved in that. Well, okay, maybe that's a distracting injury. But yeah, again, the distracting injury is one of those things that like, if it's so much, if their finger's broken and all they do is keep hollering about their finger, then maybe the finger injury is a distracting injury. Maybe they've got a terrible burn over, their arm, and then the arm is a quote unquote distracting injury.
Something you would say burns.
Yeah. So it's, maybe it's abdominal trauma. Maybe it's the fact that the person is in labor or having contractions, and maybe that's their distracting thing. So it's a pretty nebulous thing, and it's one that, like David said, probably it seems like it ought to be a thing, but it's probably not as much of a thing as we have thought it was in the past.
I think
Which again is all predicated on the fact that are you going to do anything that's actually going to make a difference for the person with your fancy toys?
I think it intuitively makes sense, but people's pain is so incredibly subjective to begin with that it almost seems an unreliable marker to me, because I've definitely had that farmer who had, clinically just massive burns all across his body and say, yeah, it doesn't feel that great. It deadpan. And then you have that person that breaks a finger and loses their mind. So I don't know that I necessarily want to base my clinical judgment off of something that could be that highly variable. I generally trust what they tell me hurts. And if something doesn't hurt and they pass the physical exam, then it's probably not something of relevance at that point in time.
Yeah. Like I can imagine if David over there with his soft hands and fancy shirts
I
were to
take
get
that as a compliment.
a cigarette burn on his hand or something like that, that would probably be a distracting injury. But, Floyd over here, gets his hand ripped off by his deer-like dog and probably could just kind of, I guess that's a problem. Guess we'll go to the hospital.
So I am an ivory tower elitist. What can I say? I cloister myself from the dangers of the world.
You can take that part out if you want.
Okay. Leave it in.
If you guys don't have any burning comments, let's tell our listeners what we think evidence-based spinal care looks like. And I know David is going to say a vacuum mattress. The majority of our listeners probably don't have one. It would be difficult for them to get one or convince their administration to purchase them. And they want to provide the best spinal care in the field. How do they do that?
So on a serious note, a couple of things real quick. Vacuum mattress technology does not actually have to be expensive or inaccessible. A lot of people may be picturing kind of the full body vacuum mattress splint with giant like T handles on it. And those things can be kind of pricey and kind of cumbersome. I would point out that I actually have rappelled into crevices in the Red River Gorge with one of those things. I have used them on all kinds of different scenes. Any place you can take a backboard, you can take a vacuum mattress splint, but yeah, they can be, a little bit cumbersome, and they can be $500 or $600. So I get it. But they also make half-back vacuum mattress splints, which are much less expensive, actually not really any more expensive than a backboard. And they're reusable. So just like a backboard, when you get to the hospital, you can remove them from the patient and take them with you. They don't have to be that expensive, but nevertheless, I
Let's
agree.
say we don't have them,
Yeah.
and we want to do it today.
Right. So I think that the evidence really says there's basically two pathways. If your patient is conscious, coherent, cooperative, coach them, maybe with a little bit of manual support of a little bit of C-spine control and help them kind of with their body mechanics to ambulate onto your cot and then help them slowly lay down backwards basically and just secure them firmly with 5-point straps. Now that does assume a couple of things, that they're able to ambulate, that they're able to assist in their own care to a certain extent. So that's kind of one pathway, is basically a patient is able to participate in their own care. So do that. The other pathway is if they're unconscious, unresponsive, uncooperative. Then I think your best tool is basically a scoop stretcher. So scoop them up. That usually is going to negate log rolling and other kinds of dramatic moves. And then again, we're gonna pick them up just kind of like we would with a backboard. So secure them into that scoop stretcher so they don't roll out or fall off. Put them down on your ambulance cot and then secure them firmly with your 5-point straps, again, just like you would for really any patient for safety's sake. And those are your two primary pathways. There may be some patients kind of, in between who, need different kinds of packaging because of their body habitus or their injuries, but those are the two things that I think we should be thinking about, the two basic kinds of patients and the two basic kinds of treatments.
Okay, so I think the end result is going to be with the patient being secured on a vacuum mattress or a stretcher firmly with a cervical collar.
I don't even know that a cervical collar is really necessary. If they're able to follow commands and participate in their own care, then I think we can coach them to keep their head and neck still. And I really do think that there's just not a strong evidence base for rigid C collars. And if we're going to be using anything to wrap around their neck, it ought to be a soft collar, something like a towel roll or blanket roll.
Okay. We have about 5 minutes left. Does anybody have anything that they really want to say?
I want to echo David's point and say, if you don't have a halfback, go buy one. So that then you don't have to buy a $10 seat collar. You can buy a $3 soft collar and take the proceeds from that and put it into, instead of, do the math or whatever, but works out to 100 seat collars or 50 seat collars or something like that. Take all that money you would have saved in that, buy your reusable halfback, cool, and then take the money that you're going to save after that as you keep using it, and put that into video laryngoscopes and norepinephrine and stuff that actually helps with the spine and with actual care for the spine injured patient, rather than these ridiculous cervical collars that don't do anything. And I would toss in real quick, I am not crazy enough to think that you can actually go out and just not put a C-collar on somebody, because that's not where everybody else is at right now. I do think that's the way that we're eventually going to end up, and somebody will see the light. But I do think that the halfback wrapped up around the guy's head is probably about the best thing we got right now, and that we can forego the rest of this stuff in order to do that. So as much as it pains me to say that David's right, I think he's absolutely right.
I have nothing else to add.
No, for just being a paramedic and all, but we should edit that part out. Sorry. Sorry, carry on.
I really want to thank you guys for coming on the show. We'll put your contact information in the show notes so that if anybody has any questions that they want to send to you specifically, they can do so. We really hope you enjoyed this podcast. If you like listening to us, then find us on Facebook or follow us on Twitter. Our handle is @CurbToBed. That's really the easiest way to get regular updates on all of the content that we put out. Thank you for listening. Bye.